Today's topic is sciatic nerve. It is the longest nerve of the body. It extends from the pelvis up to the foot. You all are doing lower limb dissections. You will be encountering the branches of the sciatic nerve in each level up to the foot. With this introduction, now you can see in osteology the hip bone. You will be seeing in the descriptive part, this is the portion of this is showing the bony relations of the sciatic nerve. This is from the pelvis, it is coming out and it's branching. Now, with the muscles intact, this is the piriformis muscle, proximal sciatic nerve emerging from the sciatic notch. This is the sciatic notch, it is emerging from the sciatic notch, and distal bifurcation of the sciatic nerve. The sciatic nerve as a whole, it comes and then it bifurcates in the medial, this is the medial hamstring muscles. Now, origin. Now, in this yellow coloring of the dorsal division and the ventral division, the pink is the ventral division. Now, from the sacral plexus, L4, 5, S1, S2, S3 and S4. It is the largest branch of the plexus. It is the largest nerve of the body. Now you can see the pink part is the tibial part, and this is the common fibular part. This whole intact portion is the sciatic nerve, and you can see L4, L5, S1, S2, S3, S4. Now, over here, L4 root value is L4, L5, S1, S2, and S3. It is the largest branch of the plexus. It is the largest nerve of the body. Now, the sacral plexus. Formation. Now, what I want to give you an idea is this. You can see the pelvis with the lower lumbar L4, L5, and this is the sacrum, and this is the coccyx. Now, what I want to stress, this is the piriformis muscle, and actually when you hold the pelvis, bony pelvis, you will be seeing the two pelvic bones with the sacrum posteriorly that articulates anteriorly with the symphysis pubis, and that forms the pelvis. Now, you can see the nerves emerging from these foramina. These are known as the sacral foramina. Actually, when you are holding the sacrum, you will see these structures, and through this foramina, the nerves emerge. Similarly, when you are studying the bones, you will be asked, what are these? It will be, with a pointer, the examiner will ask you that what are these holes? The foramina, what are these foramina? So sacral foramina. What structures come out from it? You just try to visualize and correlate your bony parts. You have to mug. It's a volatile subject, but at least you have some conception that the sacrum articulates with the pelvic bones, two pelvic bones. the right and the left, and through it is covered by different places of the hip bone are covered by muscles and fascia, and these structures from the pelvis is coming out. The nerve is the sciatic nerve. Now, formation ventral, the anterior rami of L4, L5, S1, S2, S3 and S4. Part of the L4 and whole of L5, lumbosacral trunk plus S1, S2, S3 and most of S4. Site on the posterior pelvic wall in front of the piriformis muscle. This is a beautiful picture you can visualize. This is the sciatic nerve coming down and the formation. Course and distribution. You can see the gluteus muscles are cut over. This is the piriformis muscle, triangular muscle. Just below it, it is the sciatic nerve is coming out. And it divides into two parts and goes to the leg. And then the foot, branches go to the foot. Now, with this visualization, see, it leaves the pelvis through greater sciatic foramina below the piriformis and it passes in the gluteal region between ischial tuberosity and greater trochanter, then to the posterior compartment of the thigh. Now, the hip bone has an acetabular cavity where the head of the femur articulates to form the hip joint. Now, the ischial tuberosity is part of the pelvic bone and greater trochanter is part of the femur. And termination in the middle of the back of the thigh, it divides into two terminal branches, the tibial and the peroneal. Tibial and common peroneal of fibula. Now, actually, when you go, you will see, when you dissect and see the fibular part, fibular on the lateral side, tibia on the medial side. Now, the neck of the fibula, the common peroneal nerve comes out. And it's also known as the fibular nerve. Now, branches of the sciatic nerve, cutaneous to all leg and foot. The whole of the leg and foot, it is cutaneous. Branches are there, except areas supplied by the saphenous nerve branch of the femoral nerve. The areas that is supplied by the saphenous nerve or branch of the femoral nerve. This is the These are the areas shown, the cutaneous supply. Now, this is the course of the sciatic nerve supplying the different muscles. You can see it says cutaneous branches, I've showed you. Now the muscular branches. Now the muscular branches are to hamstrings, to the hamstrings muscles, that is flexors of the knee and extensors of the hip. These are the hamstring muscles, the flexors of the knee and extensors of the hip through tibial part to hamstring part of adductor magnus. When you dissect in the adductor canal, the adductor muscles will be there and you will locate the adductor magnus, long head of biceps femoris, semitendinosus, semimembranosus. So, if you are forgetting that the nerve supply of these individual muscles, at least write sciatic nerve. The muscular branches of the sciatic nerve supplies to the hamstrings, flexors of the knee and extensors of the hip. It is flexion of the knee and extension of the hip through tibial part to it. A hamstring part of adductor magnus, long head of biceps femoris, semitendinosus and semimembranosus. These muscles, as you go and dissect, you will be seeing them very prominently. You can see the semimembranous tendon and the semitendinous tendons. The short head of biceps receives its branch from the lateral popliteal, common peroneal nerve. Here, common peroneal. Now the tibial nerve, now here is the tibial nerve. Now descends through popliteal fossa to the posterior compartment of leg, accompanied with posterior tibial vessel. Now descends through the popliteal fossa. As you see, when you the body, now you are dissecting the front of the thigh, and when the body is turned around, then you will see the popliteal fossa and the posterior region. This is the popliteal fossa, where it is, this is the part, popliteal. Now, it is accompanied, posterior compartment of the leg, accompanied with posterior tibial vessels. Now, the posterior tibial artery and vein and passes deep to the flexor reticulum through tarsal tunnel behind the medial malleolus to reach the sole of the foot, where it divides into two terminal branches, medial and lateral. Now, as you go, this is the tibial side, this is the medial malleolus of the tibia. Now, the posterior tunnel under the flexor reticulum, it goes, and where it divides into two terminal branches, medial and lateral plantar. The dorsum of the foot and the plantar aspect. The foot where we are just standing, that is the plantar. And just above, it is the dorsum. Now the muscular branches. Now the posterior compartment of leg, anterior compartment of leg. Now if you take a cross section of the it will be divided by septum and muscles in the posterior compartment. There will be muscles in the anterior compartment. With this, what you will see now, the nerve is the muscles of the posterior compartment of the leg. What is their actions? Now, the muscles of the posterior compartment of leg, plantar flexors of ankle and flexors of the toes. Flexion of the toes and plantar flexor of the ankle. Intrinsic muscles of the sole. As you go and dissect the sole, you will see the intrinsic muscles of the sole. One inverter of foot, tibialis posterior. Now one muscle, tibialis posterior, as you go and dissect, you will see it gets attached there, and it's an inverter of the foot. Now, I told you, here is the bony, this is the lower end of the femur, this is the patella, this is the tibia, And this is the medial malleolus. See, this is the medial malleolus. It is larger, that lies medially. So when you hold the tibia in anatomical position, the portion without the fibula, if you are given a tibial bone, then you lift up, see the medial malleolus, it's medially. It's the lowest, you see your own ankle and you can feel it. And study anatomy, your own body or your friend's body, or vice versa. Now, the course of the common peroneal nerve or fibular nerve, see the fibular nerve is coming down like this. So, if there is any fracture in the neck of the fibula, then there are some complications, some clinical manifestations, which we'll be discussing. Now, here it is lateral aspect of the neck of the fibula, dangerous position. This is a dangerous position. So, any footballer or anything gets a kick there, that might be injured, any accidental injuries. And superficial peroneal or musculocutaneous, which supply the lateral compartment of the leg, deep peroneal, anterior tibial, which supplies the anterior compartment of the leg. So superficial peroneal supplies the lateral compartment of the leg, and deep peroneal, the anterior tibial, which supplies the anterior compartment of the leg. Now muscular branches to muscles of the anterior and lateral compartments of the leg, dorsiflexors flexors of the ankle, extensors of the toe, everters of the foot. You can see the nerve here. This, you can see the posterior aspect. Here, this is the branches. Okay, now causes of sciatic nerve injury, posterior dislocation of the hip joint. Now, though hip joint is very stable, it is one of the most stable joint of our body, and shoulder is not so stable. So, dislocation of the shoulder joint is more common, but the hip dislocation when you are driving a car or you meet with a head-on collision with another car, that time you just put your brake, suddenly your hip, there might be a dislocation. Now, this is the area for injection. This is the tubercle of the iliac crest, anterior superior iliac spine. So when you give an injection, just don't put in like this, anyway, because you just identify the landmarks of the bony landmarks, and then you put your finger like this, and then put the injection. Because that injures the sciatic nerve, and to avoid injection should be done in the gluteus maximus or medius in the outer quadrant of the buttock. Most nerve lesions are incomplete, and it's in 90% of injuries, the common peroneal nerve is mostly affected. The common peroneal nerve fibers lie superficial in the sciatic nerve. Though that can be a question that why the nerve lesions is incomplete, And in 90% of injuries, the common peroneal nerve is mostly affected. The common peroneal nerve fibers lies superficial in the sciatic nerve. Now, here, see, this is the head-on collision and this is the driver. See, this is the part, the hip joint is dislocated. Now, sciatic nerve injury, motor effect. Now, motor effect, you see in the muscles, muscular supply of the sciatic nerve we discussed, and what you will see with immediately you won't see wasting. A patient gets a sciatic nerve injury, but he comes to you late. So, like you have heard of Dr. Vidhan Chandra Rai? Okay. These clinicians, as the patient is entering the chamber with a gait like this, then what, by seeing that and correlating his anatomical knowledge, he is to diagnose. Even in any person with high bilirubin, jaundice, if the patient is asked to open his clothes with the shirt and the armpit your vest is stained yellow. From that time your blood test and all this was not possible. So with this clinical knowledge, you can diagnose the things the patient is presenting you with. Now weak flexion of the knee, sartorius and gracilis are intact. So weak extension of the hip, gluteus maximus is intact. All the muscles below the knee are paralyzed and the weight of the foot assumes the plantar flexed position or foot drop. This position, foot drop. And the gait, see how it's walking, just like this, like that. Thop, thop, thop. And when you, after that you just put up the pant or whatever, sari or salwar, whatever it is. So you do a clinical examination. You, with a hammer, needle, that's for seeing the how the nerve is reacting. From the sole you start on, then each joint, individual joint, you just make a tap with that hammer. It's a rubber hammer. You tap, it will be, the action will say if it is paralyzed or not. So clinically, you can diagnose the stamping gait. That is the stamping gait, like thop thop kore hata. Stamping gait. You ask the patient that, you were from birth you are walking like this? Or, no sir, I met with an injury and I broke my leg. After that, this is happening. Nowadays, a patient comes with any paralysis of the limbs, it can be upper limb or lower limb, or some claw hand or something like that. You can nerve conduction velocity test. Now, the nerve conduction velocity test, they elicit with the computers, they elicit reflexes and how it is acting. That goes in a graph, gives you a picture that though much sensory loss, so much the muscular activity is lessened. So, but in district of Birbhum, in a week or 15 days at Bolpur, recently there is a center where they conduct nerve conduction velocity test. So don't be obsessed, but you have to be knowledgeable. You have to know that these things are happening. See why I'm telling you, most of the 90% clinical diagnosis can be made with your stethoscope, hammer, and your observation. And your observation comes from regularly seeing patients, hearing the history, knowing the clinical manifestations. This gives you a knowledge. So whatever you do, or you are doing from in this first MBBS, you try to acquire your clinical skills. At least you know sciatic nerve injury, this happens. You don't have to be searching for a cutaneous nerve or some big your Pacinius corpuscles under histology and then come to a conclusion. No. Whatever you see, even your heart sounds and everything, of course there is beautiful stethoscopes are coming in, electronic devices. You use, don't make the tool dominate you or the technology dominate you. Ultimately, see, you do an MRI for 8,000 rupees, CT MRI, anything, but at the end of the report, the radiologist is or pathologist or histopathologist, clinical correlation must be done. Now, this clinical, when you come to clinics, there are beautiful books, you can know, but your anatomy books of today, whatever you are having or possessing, I don't want to know what your author is, you are possessing that book. They are beautifully compiled from the different textbooks which we read, 2 years anatomy, 2 years biochemistry, 2 years physiology. So, but the mode is changed, but the questioning and all this, practical times or all this, see, it brought to 1 year's course. But you have to know the main features and you diagnose. See over here, what I told you, you just go and read through today in your dissection hall. Just read your text. By the time the other batch sees the dead body, your turn is there, you read through and you can easily correlate. Okay. Now, sensation is lost below the knee, except for a narrow area down the medial side of the lower part of the leg. This. And along the medial border of the foot as far as the ball of the big toe, up to this part. Yeah. Which is supplied by the saphenous nerve, the femoral nerve. So, that is, you can say, that sparing. The sciatic nerve is injured, but the femoral nerve is not injured. So, the cutaneous supply of this area, the medial part, is there. You can elicit. You just put your, see, it's a study in United States that CT scan of brain, the multi-center trial they have undergone, but more than 90% of the CT scan revealed normal study. So, just with a headache, someone comes, CT scan of brain. Don't do that. You clinically evaluate. There might be psychological problems. There might be ophthalmological problems, any problem of the head. It can be an ENT problem with the sinusitis or some related to some sore throat and all, having a low-grade pyrexia. These things happen actually. So clinically, you try to diagnose, but I'm telling you, you should be very judgmental regarding using the modern technology. You must use. I am for modern technology, but how far, how much? This is the thing. You will be posted in a health center in Darjeeling, in some village. So you are having no tool, you have to come to Siliguri. Or in future there will be a hospital equipped in Darjeeling. But first you have to diagnose and give a referral. So you have to know your physiology, biochemistry and this thing, your anatomy. And there's a poster in the department, anatomy is your gateway to medicine. This is a quotation I put up from my head. Because one thing I tell you, that you just, as you go along the journey, now effect of sciatic nerve injury, the motor effect, paralysis of hamstrings and movements affected, flexion of the knee, extension of the hip, all movements of the leg and foot, all muscles of the leg and foot. Sensory pain, loss of sensation of the area supplied by sciatic nerve below knee, except area supplied by the saphenous nerve. The previous slide I showed you the two differences. Sciatica, it's a very common terminology. You have heard before you joined medicine. My mother is having some sciatica. Okay, some pain in the posterior aspect. Pain from the sciatic radiates from the buttock down the leg and can travel as far as the feet and toes. When you are examining a patient in the prone position, you try to ask her to lift and her leg without flexing the knee joint, straight lift up. Then slowly you ask her to both the legs, and then you ask her to knee joint, the flexion of the knee joint, and then try to do the bicycle pedaling. Tell her to ask, and then you turn the side affected, you try to pull at the knee joint, you just pull the leg straight. Then she might say, ouch, she might be complaining of pain, and it can travel. She will say, একদম কোমর থেকে ডাক্তারবাবু একদম নিচে ওই হাঁটু গোড়ালি অবধি বুড়ো আঙুল অবধি আমার চলে যাচ্ছে. Then you can say sciatica. In your prescription, refer to and you try to see the causes. It's in the pelvis. It can be due to some injuries I discussed. It can be a big, large pelvic tumor. So you can see the pelvic in the female has the most, the organ uterus. Most puzzling, I will say, because every woman is having a different presentation of the uterus. Some few thousand hysterectomies, operation of the uterus I have done in my career, and those in the pre-USG era, and post-USG and also CT scan. It is a very puzzling thing. A small uterus can present in a different way, but a large tumor around 12 kilos, that can present in a different way. And this is the part which I want to focus. So now, the sciatica describes the condition in which patients have pain along the sensory distribution of the sciatic nerve. Thus, the pain is experienced in the posterior aspect of the thigh and the posterior and lateral side of the leg and lateral part of the foot. Now, compressed lumbar spinal nerve, herniated disc. As you will read your vertebra, even the sacrum, when you are studying the hip bone, the lumbar vertebra, the thoracic vertebra, the cervical vertebra. Now, this actually, what happens? If we, with evolution from quadrupeds, we have evolved and got a erect posture, the evolution of erect posture. That has made, see, elephant, a horse, these animals, deer, your tiger, whatever, leopard, were these fast moving animals. Even the elephant does, of course, I'm not comparing a leopard or a deer with the high speed, but as the vertebra is quadruped like this, you go crawling, but slowly, now the spine has a curvature, and this spine, each individual vertebra is separated by intervertebral disc. Now, these intervertebral discs, we will read that it actually with a compression, like if a man directly falls from a height, falls like this. His first thing is that calcaneum might be fractured, and then he might have a jerk, and that might be a disc prolapse. Long-standing duties. So, all of a sudden you carry some weight, you lift up, there will be a pain. I won't say it is complete disc prolapse, but this is a cushion between the two bony structures. There are some ligaments which will, by the way, as you progress, you will see it is, then we get an erect posture. Now, with this herniation, it is the prolapse of the intervertebral disc with pressure on the roots of the lower lumbar and sacral spinal nerves. Now, when two vertebrae are there will be spinal nerves coming, and it will come out naturally. If there is a compression, these are injured. And what I discussed is that pressure on the sacral plexus or sciatic nerve by an interpelvic tumor. Now, interpelvic tumor, I just told you about a female, but in a man or a boy who's having undescended testes or incomplete descent of testes, actually the testes that you see in the scrotal sac actually lies above, in the level of the kidney. Then slowly the kidney is in the pelvic position. Now the kidney slowly goes above and the testes descend, and progress to the scrotum by the inguinal canal, as you will be reading. Naturally, see, a boy or the mother is the first to observe that her son is not having a testes. She will come to the doctor and at this stage, you should be very, oh na na ওটা হয়ে যাবে নেমে যাবে, or callous. Don't be callous, because the testes. Why I'm coming and saying this, because now in the now here's the bladder. Okay, now here's the penis. Okay, both the testes are intact here, but sometimes this might be missing. It might be in the inguinal canal, it might be here, it might be here, it might be here. Any in the course of direction of the testes is descending, and there can be arrest, incomplete descent. Now that child is ignored, or their parents are ignored. But if this boy presents at an adolescent stage or at the age of 18, 20, then you have to take a note of it. He might be presenting with a big tumor over here on the right side or the left side. The testis is concerned. Now, what happens? You have to go immediately for a ultrasound, then you go for a CT and fine needle aspiration cytology, FNAC, to detect if it has turned into a cancerous tumor or not. So accordingly, these tumors, they compress, because in the beginning, the first slide I told you that the pelvis with the piriformis muscle and the nerves emerging through this and coming down. Now, if a testis in this location, this is the symphysis pubis. If the tumor is here, then, or he might first present with the compression on the nerves. He might come and complain to you. So you fine needle aspiration cytology and go for an operation followed by radiation or whatever it is. Now you have to have thinking one after the other, like the flow sheet in your chemistry, biology, biochemistry, the flow sheet. Similarly, in anatomy, even you are having illustrations by the different authors of the books, a flow sheet. This, the nerve supplies this. It's like that. Your thought has to be in this focused, in this way, so you can diagnose. He simply comes with his sciatica and presenting you, but you forget to see the abdomen. No, you take a total examination of the patient, so you can get a clue and refer and do your own diagnosis. Here, this is a large tumor. Now, causes of sciatica: prolapse of an intervertebral disc with pressure on one of the roots of the lower lumbar and sacral spinal nerves, pressure on the sacral plexus or sciatic nerve by an interpelvic tumor, inflammation of the sciatic nerve or its terminal branches. Even when you read embryology, you will be seeing that now you will be seeing one horseshoe kidney. Okay, the kidneys have not ascended, or it might be one single kidney over here. Now this might turn into a tumorous, there can be some tumor change. Not that it is being located in the pelvis, not that. I'm saying that when you do an ultrasound, you see a kidney. You immediately, when you examine the patient, when you have no ultrasound or anything, first visit. Then you ask the पेशाब ठीक है, urination ठीक है, your रक्त আসে না তো. These things, you just array of questions, batter. You just keep on questioning and see that what he answers. You note, just note, and try to draw a sketch just like this in your writing sheet, your pad, and then you make it a habit, because my every prescription has some illustrations if I have to illustrate. So you're not taking the examination of the pathologist, you're not taking the examination of the your radiologist, but you can give him a clue that I am focusing here. The patient complained to me. In a diagnostic center, nowadays online reports are accepted. Dr. Rajan Ghosh, he is from Chandigarh, he did his MD in radio diagnosis. So he's still some hospitals in Chandigarh. He reports every day in the evening. He sits in front of your computer and all this, and he reports. But if a clinical clue is given by the doctor, then it becomes easier to diagnose. So these is not an offshoot, what I'm telling you, because your is more clinical based teaching. Clinical questions are there. So I'm telling you that inflammation of the sciatic nerve is a terminal branches, and common peroneal nerve injury. Common peroneal nerve is an exposed position as it leaves the popliteal fossa. It winds around the neck of the fibula, enters peroneus longus muscle. Dangerous position. The common peroneal nerve is commonly injured in fractures of the neck of the fibula and by pressure from casts or splints. Now, a little girl you see here. Here is a cast. Now, suddenly there is a fracture. You're attending a health center, you're a medical officer in a health center. Then a boy comes with this type of mother brings. Now immediately, you cannot access to the x-rays or radiology. So you put a cast. If you don't get a cast, at least thick cardboard. If not cardboard, you take some bamboo, you ask them to bring in 2 strips of bamboo sliced, and you put cotton pad and just give a support. That will cause less injury as you give her. But when you are tying the bandage, you should be keep it in mind that you are not compressing the common peroneal nerve in the neck of the fibula and by pressure of the cast. Now, manifestations of common peroneal nerve injury. Now, following clinical features are now the manifestations of common peroneal nerve injury. You can see how he is moving. This posture is in The following critical features are present. Motor. The muscles of the anterior and lateral compartments of the leg are paralyzed. So, anterior and lateral paralyzed. So, the muscles related to the foot are paralyzed. As a result, the opposing muscles, the plantar flexors of the ankle joint and the inverters of the subtalar joint, cause the foot to be plantar flexed, foot drop. This is the foot drop. And inverted and attitude referred to as talipes equinovarus. This is talipes equinovarus. This type of presentation with the common peroneal nerve injury, you can see that now common peroneal nerve injury, sensory. Sensation is lost between the first and the second toes, dorsal of the foot and toes, medial side of the big toe, lateral side of the leg. This is the lateral side of the leg. Deep fibular peroneal nerve. Now, tibial nerve injury, because of its deep and protected position, the tibial nerve rarely injured. Complete division results in following clinical features. Motor, all the muscles of the back of the leg and sole of the foot are paralyzed. The opposing muscles dorsiflexes the foot and at the ankle joint and invert the foot at the subtalar joint. An attitude referred to as talipes calcaneovalgus. This is the calcaneovalgus. Now, this you will be, when you are studying your osteology, you will be again encountering these terms. And now, tibial nerve injury, sensory loss on the lateral side of the leg and foot, trophic ulcers in the sole. This is trophic ulcers. The non-healing ulcer, you look for if it has injured. Thank you.
Models. Okay. One is lock and key by Emil Fischer, induced fit by Coastland, and transition state theory, preferential transition state theory. Okay. Now, when you are asked about the types of enzyme catalysis, then you write those 6 types as general acid-base catalysis, covalent catalysis, electrostatic catalysis, metal ion catalysis, proximity and orientation effect, and preferential transition state binding theory. Fine. So this should be, you should remember, we should be able to differentiate between these two. Now, actually, what does the enzyme do in an enzymatic reaction? It is like this is time and this is energy. So in a graph versus energy versus time, the substrate, the basic level of or bare minimum energy level of substrate is higher than that of the product, and then only substrate to product transformation will take place. Now, if there is no enzyme, then can the reaction take place? Can the reaction take place without enzyme? Yes. What will be the difference? Slow. It will take more time. Correct? So, the substrate will reach from here to here, and then at the topmost point of the mountain, there is the energy required for conversion of substrate to product. This energy is called activation energy. Now this energy should be provided from the outside the system. It may be in the form of potential energy, it may be in the form of kinetic energy or heat energy converted into kinetic energy. Correct? Now at this point it is called transition state, means the enzyme, the substrate can go in on either direction to form back substrate or to form product. This is called transition state for the reaction or the substrate. Now, what is the function of enzyme? This is a non-enzymatic reaction. But with enzyme, as if the enzyme bores a tunnel through the mountain and reduces the effective activation energy. Correct? So this was a theory, this was a diagram used to explain the role of enzyme in any enzymatic reaction. It's called tunnel theory. Okay? So when you are asked about how enzymes act prior to those three models, you must explain a little bit with this diagram. Then it will be easy for an examiner to understand that you have the concept of lowering of activation energy in an enzymatic reaction as well as followed by the three models. Clear? Any doubt? This comes with a long question. Okay? Fine. So now we will discuss about the different factors which affect the enzyme activity. In your book, you might have found these 8 or 9 factors. But if you write these 6, it's more than sufficient for us. First one is enzyme concentration. Draw this graph and then explain this graph by few words. That's all. Now let me explain what is the graph about. There are two axes. One is reaction rate, another is enzyme concentration. So what is reaction rate? Rate of reaction? Rate of reaction. Take time, think and tell. Rate of reaction. What do you mean by rate of a reaction? Anyone? Product concentration by? Yes, sir. Yes, amount of product produced per unit time. Very good. Anyone else? Anyone else? Now suppose A is converted to B. Now according to, what's your name, Baba? Devayon. Devanjan. Devarun. Okay. আমি বললাম না কানেক্ট প্রবলেম আছে দেখো বাবা হাই তুলছি Devarun. So what Devarun told that in a reaction where A is converted to B, the amount of B formed per unit time is the rate of reaction. What he didn't mention is B is easy to measure. But if it happens so that B is not so easy to measure, only A you can measure, B you cannot measure. Yes. So can I write so both way it can be defined. The disappearance or utilization, rate of utilization of substrate per unit time and rate of formation of product per unit time. So these two are equal to rate of the reaction individually. Whichever will be feasible in the reaction to measure more easily, we'll consider that. Fine. So if you take the substrate, then it will be negative. It will decrease with time. If you take the product, it will increase. But what will be the effect on rate of reaction? Will it increase or decrease if the reaction proceeds? Whether you take it for substrate or product, the rate of the reaction with enzyme concentration, increasing enzyme concentration will always be upward, increasing. Why? More enzymes, higher rate. 5% can build a wall in 5 days. 10% can build a wall in less than 5 days, more than 5 days, or 5 days. 5 days. Why? Because rate will increase because of more hands. More hand, more work done. Fine? So it is very simple. With growing concentration of enzyme means we have more free vacant active site to interact with more substrate molecules, and reaction will take place at faster rate. So here you have to mention in these two, after drawing this graph, you have to mention these two. Okay, well, the reaction is actually like this. Yes. Okay, so this is called free enzyme. So your answer will be like more free enzyme, higher the rate of the reaction, but provided. Now let us come back to that building wall question. 5 men build a wall in 5 days. 10 people build the same wall in 2.5 days. Easy. What about 500 people? What about 500 people? Huh? In hours? In minutes or seconds? So what is wrong in this question? The size of the wall, it is fixed. That is wrong in this question. That means the amount of substrate, this graph will go on increasing if amount of substrate is never ending. So what is the limiting factor here? The amount of substrate. So had it been a limited amount of substrate, then this graph would have come to an end like this. Then how many more enzyme molecules you add, the rate will not increase. The rate will become standstill until all the substrates are done, and then the rate will decrease. Why? No substrate? Same wall, 500 people. Fine. So that this graph, when we are describing this graph, when substrate is not a limiting factor, add this prefix. Am I clear? But when substrate is not a limiting factor means limited amount. When amount of substrate is not a limiting factor, the graph will be like this. The rate of reaction will increase directly, or will have a direct relationship with the rate of increase in enzyme concentration. Fine? But when substrate concentration is a limiting factor, then this will happen. Okay? So a good student can depict both the diagrams and explain it. It will be very good. Now let us come to temperature. The y-axis shows the rate of the reaction and x-axis shows the temperature in degree centigrade or Celsius. Okay, starting from 10, 20, 30, 40, 50, 60, 70. What is our body temperature? 37. So between 30 and 40. So choose a line, choose a point between 30 and 40, slightly inclined towards 40. Then make it a highest point for the enzymatic graph. And see, is the graph is bell shaped. है ना? Ghanta, bell. But if the bell is both the sides same? No. With initially it will increase in small amount. Initially, it will increase slowly, but with rise in temperature, it will fall rapidly. That means when the temperature goes beyond 40 degree, that means what? How much in the thermometer? How much in the thermometer? 40 degree means how much in the thermometer? 106. Thermometer is full. Correct? This is in degree Fahrenheit. So when we have fever, we are given easy to digest food. Why? Because of this reason. At increased temperature, the enzyme activity decreases, so we cannot digest properly. So when you are having fever, we should not take biryani and chicken butter masala. Rather, we should take simple boiled rice or light khichdi kind of thing. Now this you have to explain in 3 segments. First segment, you have to explain what happens with growing temperature, increase in temperature, what happens at the top and what happens when it increases beyond the optimum temperature. Okay, so first thing you have to mention point wise if you go. Have you drawn the diagram? Now write the first point. It's a bell shaped graph. Bell shaped, B-E-L-L, bell shaped graph. Yeah. Next point. The rate of the reaction increases initially with the increase in temperature, due to increased Brownian motion or effective kinetic energy, bracket লিখতে পারো half mv square, effective kinetic energy of participating molecules. দেখা গেছে ফার্স্ট বেঞ্চ হয়নি? লস্ট যা দাদা আমি তো মুখস্থ করে আসিনি, তোদের মতন ভালো স্টুডেন্ট থোড়াই আমি, তাই না? So rate of the reaction increases with the increase in temperature initially due to increase in Brownian motion or effective kinetic energy of the participating molecules. মানে both enzyme molecule as well as substrate molecule. Now enzyme and substrate molecule like this. Like this, they always collide. But at some moment, when you increase the temperature, then like this, and then reaction happens. then stops. Okay? So it increases effective kinetic energy. When the kinetic energy is less, the sound will not reach to the last bench. When the kinetic is more, sound is more. So more kinetic energy will be converted to activation energy. Correct? So this is due to Brownian, increased Brownian motion. Now at temperature near 37 degrees Celsius, at temperature, next line, at temperature near 37 degrees Celsius, most of the enzyme reaches highest rate of the reaction. It is called optimum temperature. It is called optimum temperature. No? Optimum temperature. Now, next line. At temperature beyond 40 degrees Celsius, at temperature beyond 40 degrees Celsius, the rate of the reaction rapidly decreases. The rate of the reaction rapidly decreases due to denaturation of enzyme molecule. Okay? Exceptional, some exceptions are there. So TAC DNA polymerase, TAC, T-A-Q, TAC DNA polymerase, or the enzymes from bacteria of hot spring can withstand temperature as high as 90 degrees Celsius. TAC DNA polymerase, or for example, for exception, TAC DNA polymerase or enzymes from bacteria of natural hot springs can withstand temperature as high as 90 degrees Celsius. Stop. Okay. Now here another term is always, sometimes it is asked, Q10. Q10. What is Q10? Capital Q, then small 10, 10. Q10. Write down. Change in the rate of the reaction. Q10 is defined as change in the rate of reaction with increase in 10 degrees Celsius of temperature. Okay? Suppose you have been given an enzyme and you have been asked to find out the optimum temperature of that enzyme. How do you perform? How do you know where it will fall? Between 20 and 30, between 30 and 40, between 40 and 50, what? You don't know, new enzyme. So, what you will do, you will prepare 1, 2, 3, 4, 5, 6, 7. 7 fixed temperature water bath. Incubate for same time, measure the rate of the reaction. So, you will get 7 values. Now, the 7 values will be increasing initially, then decreasing. So, sometime you might get, say around 50, 10 is equivalent 50, same value, correct? Then 20 will be like this here, 40 high, 30 high. So as long as the Q10 will be very less, you will find which Q10 is having very less difference. Your optimum temperature will fall within that 10 degrees Celsius gap. So now you design a second set of experiment with, suppose it falls around between 30 and 40. So now you design second set of experiment with temperature 31 degree, 32 degree, 33 degree, 34, 35, 36, 37, 38 and 39 and 40. Now you will get an detailed graph, slowly increasing, reaching the highest at 37, then decreasing. So 37 is the optimum temperature. So Q10 helps to understand that between which 10 degrees Celsius the enzyme possesses its highest activity. What is it? Why is it helpful? When we don't know the exact optimum temperature and we are working with multiple enzymes, then we have to choose an somewhat which is standard enzyme, standard temperature at which all the enzymes will work in a normal way. May not be at optimum high speed, but in a satisfactory good speed. So that's why we need to know the Q10 of different enzymes while working in a multi-enzyme system. So our body has kept that 37 degree, which is near to optimum temperature of many enzymes, but not all. Followed? That's all. Next. Fine. Whatever you have written, just go through it. All right. pH. Draw this diagram. Here you have to remember many examples. Right? See, here the shape of the bell is much better compared to the temperature graph. Correct? Here also it is a bell-shaped graph. But problem is range is 1 to 10. How much range might go to? 1 to 14. Can it be 15? No. pH cannot be more than 14. So up to 1 to 14 you can write. 1 to 14 you can write. And then you can draw this optimum pH of pepsin, salivary amylase, and then alkaline phosphatase. Then you must explain what is the role of pH in maintaining or controlling the rate of the reaction or enzymatic activity. Now, if you can recall from the last class, my last class, active site contains a substrate binding site or catalytic site. So there lies few important amino acid residues which are either positively charged or negatively charged. So with pH, the charge of these catalytic residues will alter. Do you agree or not? Do you agree? Fine. Why? Because higher pH means lower H plus ion concentration. So you are removing plus ions and adding minus ions. So they might go and occupy the positively charged catalytic sites. They might go and occupy the negatively charged catalytic site. Fine. So the optimum pH, the pH, the activity will decrease or increase. Both way it can go. Some enzymes will show decreased activity, some enzymes will show increased activity. So what is the normal charge? Normally the charge around human serum albumin at normal body pH. Negatively charged. If you reduce the temperature, reduce the pH, what will happen? It will become positive. The same albumin in the blood will become positively charged. Followed? So Here you have to write that pH of the medium dictates the ionic state of catalytic residues present at the substrate binding site. Stop. This phenomena, this alters enzymatic activity greatly. No? Stop. So at higher pH it will be positively charged. At lower pH it will be, right, at higher pH it will be negatively charged. At lower pH it will be positively charged mostly. When our blood pH is normal pH is 7.4. Now, have you heard of this term isoelectric pH? ठीक है बोलो yes sir. তুই বললি yes sir. হ্যাঁ তারা তুই বলেছিস yes sir. হ্যাঁ বলেছি তো হ্যাঁ ঠিক আছে. হ্যাঁ molecule has no net charge, zero net charge. কিছু হয় বল, নো নেট চার্জ নয় জিরো নেট, কি যে বলছি। আচ্ছা আইসোলেটিক পিএইচ কে এইভাবে লেখে, এইভাবে লেখে, এইভাবে লেখে না এইভাবে লেখে এটা? আচ্ছা আমি জানি না, জিজ্ঞেস করছি জানি না। তা পিআই অফ দেখ তো কি কি মানে, এটা মানে কি হয়? তুই তো মলিকুল বললি, সেই মলিকুলটা কি, প্রোটিন না অ্যামিনো অ্যাসিড? অ্যামিনো অ্যাসিড। কে কে বলে অ্যামিনো অ্যাসিড? দাঁড়া, অ্যামিনো অ্যাসিড বলেছে যে, দাঁড়া তুই বস, তুই বলছিস অ্যামিনো অ্যাসিড, প্রোটিন নয় তো? আচ্ছা, what do you know about isoelectric precipitation? এমনি এমনি, হ্যাঁ মা বাড়ি নাকি? বলো, তুই বল এবার আইসোলেটিক প্রেসিপিটেশন বল। হ্যাঁ হ্যাঁ খুব করে হ্যাঁ বলে, চিৎকার করে হ্যাঁ বলেছিস, বল। এ কথা হলো, আমি ভাত রান্না করতে পারি কিন্তু নামাতে পারি না। আরে বস, দেখো আইসোলেটিক পিএইচ is a term, is a pH at which the amino acid shows no net charge, জিরো নয়, নো নেট চার্জ। প্রথমে পার্থক্য আছে, জিরো হলে কিছু হয় না। এখানে আমার ফিজিক্স পড়াতে বলিস না, there is nothing called zero, তাই না? আচ্ছা তাহলে পিআই অফ এ প্রোটিন কি হবে? PI of an amino acid is very easy to explain because it's only single molecule, you have no net charge, it's called PI. But isoelectric pH of a protein, Protein is made up of number of amino acids. So how do you calculate? Average of what? So suppose there are 30 acidic amino acids and 70 basic amino acids in a 100 amino acid containing protein. The proportionate average of all the acidic and basic amino acid residues. So it comes around for albumin 4.5. For albumin it comes around 4.5. Fine. Now for casein, jal khao, drink water. For casein, what is casein? Casein. Somehow you want to pronounce it a lot, not casein, but casein. So the casein is a phosphate containing milk protein. Fine. It has pi oh sorry, এটা 4.5 কর আর অ্যালবুমিন হচ্ছে 4.6. Okay. So one of the tests to identify protein is the isolated precipitation. So casein remains associated with albumin. If you take milk, milk contains albumin, lactalbumin. So it has got 4.6 pi and casein is having 4.5. So you have to overcome albumin, overtake albumin, then you have to reach casein, right? So how it is possible? Because the moment you cannot reach, you cannot decrease the pH from 4.7 to 4.5. You have to go to 4.6, then 4.5. But the moment you go to 4.6, the albumin will precipitate and you will be in, your experiment will be jeopardized. Why? Because casein will be mixed with albumin. Casein will be mixed with albumin. So for doing such test, we add one what? What do you mean by BCG? For doing that, we add one vaccine, BCG. Some indicator, bromocresol, green, BCG, bromocresol, green. The feature of bromocresol green is, a property of bromocresol green is, it binds with albumin. So the moment it binds with albumin, and then if you lower the pH of the medium, then albumin will not precipitate. Only casein will precipitate when you reach the pH at 4.5. Clear? Called isoelectric precipitation of casein. So casein has got an isoelectric pH at which it shows highest precipitability or lowest solubility. So how to define pi of a protein? Pi of a protein is a pH at which it shows least solubility. Am I clear? Next. Now we come to examples. Now let me toss two terms. Ectoenzyme, endoenzymes. Well, ectoenzyme, endoenzyme, bolo. Anyone? Quick, fast. Anyone? Ectoenzyme, endoenzyme. Anyone? Ectoenzymes are extracellular enzymes. Endoenzymes are intracellular enzymes. Now, find this. Are there any endocellular enzymes? Endoenzymes? Endoenzyme. Ecto, all are ectoenzyme. Right? So ectoenzymes are found to have different pHs, different optimum pH other than 7.4. Bosho. Why? Because they are involved in digestion process. Okay? What is the function of pepsin? Digest protein. Where? In stomach. What is the pH of the stomach juice? Between 1 and 2. Right? What is between 1 and 2? So, what should be the optimum pH for pepsin? Actually, it is 2.5. It is higher, optimum. It doesn't mean you have to reach there. Near about means it functions well. Fine. Yeah, fine. Now, salivary amylase. From where it is secreted? Salivary amylase secreted from salivary glands. Okay. What is its optimum pH? 6.8. Is it possible to achieve that? As long as we chew the food inside our mouth. Is it possible to still continue that? Yes. When the bolus enters into the stomach, the outside pH is changed to acidic, but the inside is still alkaline. So, bolus is digested from inside out. The moment it reaches the small intestine, duodenum, the second part of duodenum, or beyond that, again the climate is alkaline, so it can function. Okay, even pancreatic amylase also same. Now, alkaline phosphatase between 10 and 12, its optimum pH is between 10 and 12. What is its function? It is secreted from the biliary tract. Where? In the small intestine. What is the function? To remove phosphate groups. To remove phosphate groups from organic phosphate compounds. Right? So this will take place at higher pH. Why? Because beyond second part of duodenum, the atmosphere is alkaline. So it is high. Now, what is an optimum pH of acid phosphatase? There are some compounds which are acidic in nature but still contain phosphate. For them to utilize, we need acid phosphatase. Between 4 and 5. So draw a graph between 4 and 5 and write acid phosphatase. Okay? Fine? Now, all these are ectoenzymes. Now, let us come to an endoenzyme. Inside the cell, outside the cell, pH might vary. Saliva, alkaline. Gastric juice, acidic. Again, alkaline in the small intestine, large intestine, correct? But inside the cell, all are having same pH. 7.4, slightly alkaline. So all the metabolic enzymes participating in the metabolism, they must have their optimum pH at or near 7.4. So all endoenzymes must be having optimum pH near 7.4. Ectoenzymes may vary. Now name one endoenzyme: hexokinase, glucokinase, aldolase, PFK1, PFK2. Pyruvate dehydrogenase, lactate dehydrogenase. Correct? Any enzyme that participate in metabolic pathway are endoenzyme. Now we'll stop here. We'll continue later on. Still we are left with the substrate, which will take little time. And this one you have to explain, steady state kinetics. Okay, and this one is a reduction of the equation, different forms. And this one.
Now, the myocyte, muscle fibers, cells of muscular tissue, muscles are derived from mesoderm. Now, this is a embryology te porbe, ectoderm, endoderm, mesoderm. Now, muscles are derived from the mesoderm. In muscle, the sacrolemma is plasma membrane, sacroplasm is cytoplasm, and sacroplasmic reticulum is the endoplasmic reticulum, and sacrosoma is mitochondria. Now, introductions. Histologically, the muscles are classified into three groups. Eta bhaiba, দেখো এখানে তোমাকে আমাদের সময় ছিল না এগুলো। এই যে ভাইবা, এটা কোয়েশ্চেন হতে পারে। স্কেলেটাল মাসল, কার্ডিয়াক মাসল, স্মুথ মাসল। তো এইসব আমাদের আগে বলেনি, আমরা যখন পড়াশোনা করেছি। তো তোমাদের একবারে মোটামুটি ফরম্যাটে তুমি খালি হাঁটো, ওই তাহলে দেখবে তোমার টেনশন থাকবে না। তাহলে কি হতে পারে? হিস্টোলজিক্যালি দ্য মাসলস আর ক্লাসিফাইড ইন্টু থ্রি গ্রুপস। হ্যাঁ, থ্রি গ্রুপস: skeletal muscle, cardiac muscle, and smooth muscle. Now I have placed few slides there. Cardiac muscle পরপর দু তিন মাইক্রোস্কোপে আছে। Smooth muscle is there, and your skeletal muscle. Now physiologically, muscles are classified as voluntary, skeletal muscle under control of our will, and involuntary, cardiac and smooth muscle not under control. Now, একটা পিজা হাটের পিজা খেলাম, একটা বার্গার খেলাম ডমিনোস, it goes down from the mouth to the stomach. Now, you don't know how it is being churned up and mixed with acids and enzymes and all in the stomach. It's not under your control. তুমি খাওয়ার পরে বললো না এটা কার্ডিয়াক এন্ডের থেকে যা, তুমি করতে পারবে না। পাইলোরিক এন্ডে তাড়াতাড়ি বেরিয়ে যা, আমি আরও খাবো, হ্যাঁ, সেটা হবে না। You cannot control it. So it is now voluntary, involuntary. Now cardiac তুমি কন্ট্রোল করতে পারবে কি? রামদেব বাবাও করতে পারবে না। হ্যাঁ, so you see the heart pumping from when you read the embryology, you see there will be a fetal pole, and then slowly by weeks it will come into a tube, then chambers, then inlaying, একটার পর একটা চলছে। তুমি প্রথমে যখন একটা after a shower you take a bath, you wear a vest, then you wear your shirt, then you put on a tie if you have. So like that it is being laid. So similarly, this developmentally it is from mesoderm, and now involuntary, cardiac and smooth muscle. So now voluntary, now biceps muscle. Hrithik Roshan, Salman Khan, Shah Rukh Khan. Whose biceps is big? I think Hrithik Roshan's biceps, I feel that, I think it is big. So if you just, in nowadays Cassius Clay, the boxer. So one thing I tell you that now skeletal muscles, also called striated muscles or voluntary muscles under will, because of skeletal attachment responsible for locomotion. Now you are reading, dissecting the lower limbs. Now the bony attachment from origin to insertion. You see all the muscles which is coming from the hip bone or the femur are getting inserted in their respective position, as you see. Now, visceral striated muscles, microscopically identical to skeletal muscles, confined to the viscera such as tongue, pharynx, peripheral part of diaphragm and upper two-thirds of the esophagus, involved in speech, breathing, swallowing and coughing. Now, this microscopically identical with the skeletal muscle, confined to viscera such as tongue, pharynx. I have demonstrated a stomach. You will have and tongue. Beautiful slide of tongue is there. To just view, see, and whatever you see in 10x magnification, you will be. Now regarding the breathing, now diaphragm which separates the thorax from the abdomen. Now what is actually is that it's a muscular peripherally, it's like a tent. Now it is in the central portion, it is the central tendinous part. So the histology changes and the peripheral part where it is inserted in the ribs and your vertebra and all this. When you read diaphragm, you will be seeing in the dead body, also in the thing. Now this is now identification features of skeletal muscles. Skeletal muscle fiber is a multinucleated syncytium of varied length. These are the muscle fibers, and these are the connective tissue in between, and peripheral nuclei, and this is transverse striations. Now, nuclei are flat and located in the periphery of the cell, just beneath the sacralema. Now, sacralema, microscope देखते हो ना, nucleus टा देख ले, skeletal muscle pattern टा देख बे, cardiac muscle pattern टा देख बे. Now, see these magnification of skeletal muscle, you see it in your textbook, and also view it in the slide. So this is 100x, and this is 400x, this is 1000x. These are higher magnification, but you cannot focus in that. So we see the book and correlate. This ultrastructure of skeletal muscle you see in standard textbooks. Now, these are more of theory. Types of skeletal muscle fibers based on diameter and color of the muscle fiber: red, white, and intermediate. It was the type 1 fibers, low, slow. Anyway, now what I would ask 10 students. That means that nuclear stage, it will be deep blue, and this is pink. So you just see one thing I tell you. You come and see. Now this is the cardiac muscle. এটা তত খারাপ নয়, খালি দেখে নাও, দেখো এক এক করে দেখো, ওখানে একটা কার্ডিয়াক আছে, দেখো দেখো সব এক জায়গায় ক্রাউড করো না. How many of you have purchased your notebook, lab book? You have drawn your microscope? Okay, signed by your respective teacher? Okay, because see, what I want to stress, because these things count. Now, whatever it is, you get a basic idea and knowledge regarding every tissue. This is one thing. Second thing, whatever you see you see you make it a point till you might become a histopathologist or you might not, but you focus in 10x. You see the total slide and then scan with the microscope stage. You can just move forwards and this thing. And the basic thing is that you move from left to right, then again right to left, you will left to right and right to left. This way you just scan, focus first and see what you are seeing. And try to, it's there, but try to focus on the best, because a histology section, when it is being prepared, a tissue is being prepared. Say I take a transverse section. I might take a longitudinal section. It is given in the books, you will see. Just read over. Because this basic knowledge you have to know. And now what I want to stress is that after you see it, you try to, at least the write up part, you might not get the thing there to draw and this thing, but the write up, whatever the slide content from your histology textbook, you just write. Another thing is that you get it signed by your respective teacher, whoever is present, by Dr. Yogesh Sonteki from PGI Pondicherry, the human histology. Next, muscle. Better. Down next. Now, as per, now this is the terminology. In our time, it was not there. Competency-based undergraduate curriculum. In this format, you will be, for each subject, you will be going in. And now describe and identify various types of muscles under the microscope. Classify muscles and describe the structure, function, correlation of the same. Describe the ultrastructure of muscular tissue. Now, ultrastructure, it will see it in electron microscope. Actually, there is no electron microscope here. You can't forget, but you see in your books. Okay? Any standard textbook? Now, introduction. The property of contractility is well developed in muscular tissue. Contraction, muscle, the locomotor. You walk, you do all this muscular activity is done. The myocyte, muscle fibers, cells of muscular tissue. Muscles are derived from mesoderm. Now this is a embryology te porbe, ectoderm, endoderm, mesoderm. Now muscles are derived from the mesoderm. In muscle, the sacrolema is plasma membrane, sacroplasm is cytoplasm, and sacroplasmic reticulum is the endoplasmic reticulum, and sacrosoma is mitochondria. Now, introductions. Histologically, the muscles are classified into three groups. Eta bhaiba, দেখো এখানে তোমাকে আমাদের সময় ছিল না এগুলো। এই যে ভাইবা, এটা কোয়েশ্চেন হতে পারে। Skeletal muscle, cardiac muscle, smooth muscle. তো এইসব আমাদের আগে বলেনি, আমরা যখন পড়াশোনা করেছি। তো তোমাদের একবারে মোটামুটি ফরম্যাটে তুমি খালি হাঁটো, ওই তাহলে দেখবে তোমার টেনশন থাকবে না। তাহলে কি হতে পারে? Histologically, the muscles are classified into three groups. Three groups: skeletal muscle, cardiac muscle, and smooth muscle. Now, I have placed few slides there. Cardiac muscle, পরপর দুটো মাইক্রোস্কোপে আছে. Smooth muscle is there, and your skeletal muscle. Now, physiologically, muscles are classified as voluntary, skeletal muscle under control of our will, and involuntary, cardiac and smooth muscle not under control. Now, একটা পিজা হাটের পিজা খেলাম, একটা বার্গার খেলাম ডমিনোস, it goes down from the mouth to the stomach. Now you don't know how it is being churned up and mixed with acids and enzymes and all in the stomach. It's not under your control. তুমি খাওয়ার পরে বললো না এটা কার্ডিয়াক এন্ডের থেকে যা, তুমি করতে পারবে না। পাইলোরিক এন্ডে তাড়াতাড়ি বেরিয়ে যা, আমি আরও খাবো, হ্যাঁ, সেটা হবে না। You cannot control it. So it is now voluntary, involuntary. Now cardiac তুমি কন্ট্রোল করতে পারবে কি? রামদেব বাবাও করতে পারবে না, হ্যাঁ। So you see the heart pumping from, when you read the embryology, you see there will be a fetal pole, and then slowly by weeks it will come into a tube, then chambers, then inlaying, একটার পর একটা চলছে। তুমি প্রথমে যখন একটা আফটার শাওয়ার ইউ টেক আ বাথ, ইউ wear a vest, then you wear your shirt, then you put on a tie if you have. So like that it is being laid. So similarly, this developmentally it is from mesoderm. And now involuntary cardiac and smooth muscle. So now voluntary, now biceps muscle. Hrithik Roshan, Salman Khan, Shah Rukh Khan, whose biceps is big? I think Hrithik Roshan's biceps, I feel that, I think it is big. So if you just, in nowadays Cassius Clay, the boxer. So one thing I tell you that now skeletal muscles, also called straighted muscles or voluntary muscles under will, because of skeletal attachment responsible for locomotion. Now you are reading, dissecting the lower limbs. Now the bony attachment from origin to insertion. You see all the muscles which is coming from the hip bone or the femur are getting inserted in their respective position, as you see. Now visceral straighted muscles, microscopically identical to skeletal muscles, confined to the viscera such as tongue, pharynx, peripheral part of diaphragm and upper two-thirds of the esophagus, involved in speech, breathing, swallowing and coughing. Now this microscopically identical with the skeletal muscle, confined to viscera such as tongue, pharynx. I have demonstrated a stomach. You will have and tongue. Beautiful slide of tongue is there. You just view, see, and whatever you see in 10x magnification, you will be. Now regarding the breathing, now diaphragm which separates the thorax from the abdomen. Now what is actually is that it's a muscular peripherally, it's like a tent. Now it is in the central portion, it is the central tendinous part. So the histology changes, and the peripheral part where it is inserted in the ribs and your vertebra and all this. When you read diaphragm, you will be seeing in the dead body, also in the thing. Now this is identification features of skeletal muscles. Skeletal muscle fiber is a multinucleated syncytium of varied length. These are the muscle fibers, and these are the connective tissue in between, and peripheral nuclei, and this is transverse striations. Now, nuclei are flat and located in the periphery of the cell, just beneath the sacralema. Now, sacralema এগুলো এই মাইক্রোস্কোপে দেখতে পারবে না, নিউক্লিয়াসটা দেখলে স্কেলেটাল মাসলের প্যাটার্নটা দেখবে, কার্ডিয়াক মাসলের প্যাটার্নটা দেখবে। Now, see these magnification of skeletal muscle, you see it in your textbook and also view it in the slide. So this is 100x and this is 400x, this is 1000x. These are higher magnification, but you cannot focus in that. So we see the book and correlate. The ultrastructure of skeletal muscle you see in standard textbooks. Now, these are more of theory. Types of skeletal muscle fibers based on diameter and color of the muscle fiber: red, white, and intermediate. Red fibers are type 1 fibers, low, slow. Anyway, that means that nuclear stain, it will be deep blue, and this is pink. So you just see one thing I tell you. You come and see. Now this is the cardiac muscle. এটা তত খারাপ নয়, you make it a habit. দু চারবার দেখতে দেখতে এই হ্যাবিট হয়ে যায়। আর এটা খালি তোমার যদি কোনো কমপ্লিকেশন থাকে, if you feel that there is some problem in viewing, then you call me, I'll be there. I'm here, I'm not moving off. You just see the slides which I put under the microscope. Please see. ম্যাক্সিমাম এগুলো তোমার যে ফাঁকগুলো আছে সেটা এন্ডোমাইসিয়াম। আর এখানে দেখবে যে ছোট ছোট স্পট, একটা মানে নিউক্লিয়ার স্টেনটা নিয়েছে খুব মাইনিউটলি। দেখো আমার তো ক্যাটারাক্ট আছে, তবু বলছি, হ্যাঁ এইরকম দেখো, এখানে এই যে এরকম এরকম দেখো, ইউ সি ইট, ইউল গেট ইট, হ্যাঁ গেট ইট, ইউল গেট ইট। এই স্টেনটা হচ্ছে HND স্টেন। এবার হেমাটক্সিলিন অ্যান্ড ইওসিন। নাও হেমাটক্সিলিন is a nuclear stain, and eosin is cytoplasmic. ঠিক আছে, বাদ বাকিটা তোমার হিন্দিতে একটা কথা আছে, রটনা ক্রোমোজোম দেখবো তা না। এবার ধরো তোমার একটা ক্যান্সার সেল, একটা এই মাইটোসিসের মাইটোটিক ফিগার্স ইউ উইল সি, এটা আবার এরকম এটা স্প্লিট করে গেছে। তুমি যখন হিস্টোপ্যাথোলজি স্লাইড দেখবে, হ্যাঁ একটা ক্যান্সারাস ইয়েতে, তখন কিন্তু তুমি দেখতে পাবে, একটা ভালো মাইক্রোস্কোপ হলে সব দেখতে পাবে। তাহলে নালে একটা হিস্টোপ্যাথোলজিস্ট এই মাইক্রোস্কোপিতেই দেখছে তোমার, সে কি করে বলছে মাইটোটিক ফিগার্স বেশি আছে, মানে একটা স্কোমাস সেল epithelial tissue. You have viewed, okay. Now, if it is cancerous, then this squamous cell epithelium will divide. Rapid division of that cell will be there. Naturally, if there is rapid division, how will you identify between the normal? You know the normal first, এখন by the way, when it's clinical oriented, naturally I am supposed to tell you that mitotic figures you will see in abundance. You will see at epithelial lining. এরকম ধরো সেলসগুলো আছে একটা, ঠিক আছে, এইখানে একটা গ্রোথ হয়ে গেছে, ধরো ইসোফেগাস, এখানে কার্ডিয়াক, এইখানে এন্ডে একটা ওভার গ্রোথ হয়ে গেছে, একটা স্মুথ ছিল, এই দিকে স্মুথ আছে, এই এপিথেলিয়াল লাইনিংটা, এই এন্ডে এই দিকের দিকে, হ্যাঁ, ইটস এ টিউব লাইক দিস and you prepare a slide, you will see that এখানে তোমার mitotic figures, mitosis will be more, সংখ্যায় বাড়বে। Get it? Am I clear? আমি হার্টের এই থাকলো, এরকম থাকলো, এখানে এট্রিয়াম, এটা ভেন্ট্রিকল, ঠিক আছে। এবার আমি এখান থেকে এটা পেরিকার্ডিয়াম দিয়ে ঢাকা আছে, ঠিক আছে। সিমিলারলি এটা স্টমাক, এখানে পেরিটোনিয়াম দিয়ে ঢাকা আছে, মেসোথেলিয়াল লাইন। এবার এখান থেকে আমি একটা এইটুকু টিস্যু নিলাম। সিমিলারলি হার্ট থেকে আমি এরকম একটা টুকরো নিলাম। নাও what happens? Now this is the stomach from external to interior. একটা সেকশন যখন দেখছো তখন তোমার এখানে তার পেরিটোনিয়াল লেয়ার আছে, তার মানে তোমার এখানে তোমার ব্লকটাতে তোমার হলো টিস্যু, তারপর সেকশন কাটা হলো, ধরো এইটা এসছে একটা স্লাইডে, ঠিক আছে। নাও এখানে তোমার এটা তোমার পেরিটোনিয়াল লেয়ার, সেরোসা,
yes.
মেসোথেলিয়াল, দেন কাম দি মাস্কুলার, তারপরে এখানে লুজ কানেক্টেড টিস্যু, দেন দি
Plexus.
epithelium. So when you are saying what I am trying to say is that you and 10x এ দেখবে, তাহলে তুমি মুভ করলে এটা এবারে এরকম করে দেখবে, তোমার পরীক্ষায় তোমাদের করতে হবে না, হ্যাঁ, কিন্তু তোমাদের ফোকাস করা থাকবে, তুমি শুধু ফাইন অ্যাডজাস্টমেন্ট করবে তোমার অ্যাকর্ডিং টু ইয়োর eyes, lens, power, everything. So you see it like in this form. Now you view like this, okay? And now here this is the part, okay? Now what I am trying to say, know the gross, তার মাসল, হ্যাঁ, এবার তার টোটাল স্কিন, এবার আমরা তো এই স্কিন সমেত মাসল হিস্টোলজিতে দেখায় না, মানে ইউ জাস্ট থিঙ্ক দিস ইজ দি বাইসেপস, এবার দিস ইজ দি স্কিন, স্কিনের একটা লেয়ার হলো, তারপরেই সাবকিউটেনিয়াস টিস্যু, তারপরে মাসল ফাইবার্স। In between, it is supplied by blood vessels.
Yes.
Then the nerves are there, the sensory nerves. Huh? Now, these neurological strains are different. That is, you will see it in a different form. But I'm saying now skin, now muscle. Now muscle is voluntary, involuntary, you have to read. Smooth muscles. Accordingly, you get it in the section. Now muscles, now if this biceps is like this, now if you take a cross section, then you will view it like this, cross section. That means it will be like this. The fibers are like this, so you will see it like this, cross section. But if you see it in In this thing, longitudinal section, then you will see in fibers like this. But each myocyte has a nucleus. And in between, now you see the muscles contract. So it has to have some gliding
sliding surface.
So এই যে ইয়েগুলো থাকে, that you will be seeing. In between, you see one thing I tell you, you just come. এই দেখো, these the epithelial lining, then the muscle, it's a movement, voluntary muscles. You can see the একদম intact section আছে, and একটা দুটো